Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I'm going to discuss with you all the ureteric injury. Let's suppose we have a scenario in which a 30-year-old female patient to undergo emergency hysterectomy for excessive bleeding during C-section. On post-op day, patient start complaining of left lung pain, her vitals are normal, and her urine output in polycatheter 1800 and the drain output was 400 ml. The fluid sent for spot creatinine, and the spot creatinine is 45 mg per deciliter, while her serum creatinine is 1.2 mg per deciliter. And the question is that what's your diagnosis? How this injury can be prevented, and if you have been called during surgery, how you would identify the injury, what investigation you will order to confirm your diagnosis, what are the principles of surgical management of ureteric injury, and if a patient is vitally unstable, how will you manage this patient, and what are the delayed treatment options for ureteric injury. We will be discussing all these questions one by one in this presentation. The blood supply of the ureter is important because in various procedures you should be aware of this blood supply, where to give incision in various part of the ureter. So the understanding of this blood supply is important. The blood supply of the proximal ureter is medially, mid ureter is posteriorly, and distal ureter is laterally. So you can just remember this by MPL: medially, posteriorly, and laterally. So you can remember this by this formula. Now the severity scale for ureteric injury is also important, in which the grade 1 is the hematoma or contusion or hematoma without devascularization, grade 2 laceration that is less than 15% transaction, and grade 3 laceration more than 15% transaction, and grade 4 is the laceration in which there is a complete transaction or complete tear with less than 2 centimeter devascularization, and grade 5 is the avulsion, or we can say that the complete transaction with more than 2 centimeter of devascularization. So the severity index of ureteric injury is important. Now the question is that how these injuries can be prevented. This injury can be prevented by the intimate knowledge of the location and the knowledge of the anatomy, visual identification of the ureter, meticulous dissection, careful intraoperative dissection in their proximity, good hemostasis, intraoperative hydration and diuresis, and preoperative stenting. All these can help to prevent the iatrogenic injury. And what can be the complication of these ureteric injury? It can either spontaneously resolve and healing, it can lead to urinoma or urinary ascites, it can lead to spatulous formation, it can lead to stenosis or stricture, and it can even lead a non-functioning kidney if it's left for a long time. So there was a question, what are the general principle of ureter repair? So the general principle is that to debride all the devitalized tissue, a meticulous and sufficient mobilization of the ureter to permit attention pre-anastomosis, and to preserve the ureteral adventitia and vasculature to ensure adequate ureteral blood supply. Ureteral end should be spatulated 5 to 6 mm. Spatulation is performed for both ureteral segment at 180 degree apart, and with a fine absorbable suture is placed in the corner of one ureteral segment and the apex of the other, and the two ends of the suture are tied outside the ureteral lumen. The opposite corner and apex are similarly sutured and approximated. The anastomosis may be completed by running these two sutures continuously and tying them to each other or in interrupted fashion. You can do it in continuous or with the interrupted suture, and use absorbable suture 40 or 30 PDS. And the anastomosis should be tension free, watertight, better, and that should be done on internal stenting and placed in an external drain. So these are the principles. So, what are the investigation? The investigation for delay presentation includes part creatinine, which we have already discussed, and it should be 25 to 450 milligram per deciliter when the fluid is urine. And the imaging is important for if a patient present delay. That's include ultrasound QB, in which you will look for hydronephrosis, urinoma, and cortex of the kidney. Then CT urogram, which is with delay images, and that is the gold standard investigation. And you can go for retrograde phylogram, and RPG is the most accurate because it can tell you and you can evaluate the location and extent of ureteral injury. And if there is any suspicion with a poor cortex and for lung hydronephrosis, you can also go for renal scan to make sure that the kidney is functioning or non-functioning. So you can face three scenario. One, the patient can present 2 or 3 months of the injury or 10 days of the injury, and if they call you during surgery to come and identify and help us in the identification of the intraoperative uh, injury of the ureter. So we have some principle like go and enter into the retroperitoneum and try to identify the ureter, which is located just posterior to the common iliac artery, like we remember that via formula water under bridge. So this is the one of the good landmark to identify the ureter and look for any contusion or laceration. If you are unable to identify, you can give the patient Lasix 40 milligram, and that can reach into the system and can give you a gush of fluid from that area just in a 5 minute. You can also give IV dye like that can identify the injured area, and you can also perform pyelogram by injecting the contrast direct into the renal pelvis or by retrograde injecting during cystoscopy with the help of ureteral catheterization. So these can help to identify the intraoperative ureteric injury. So if a patient is on a table and you have been called, the most important things is to identify if the patient is stable or unstable. If the patient is unstable, what option you have to for this unstable patient? The poor option for damage control and ureteral injury. Number first, do nothing but plan a reoperation when the patient is more stable, usually within 24 hours, or place a ureteral stent into the proximal end of the transected ureter and externalize the stent to the skin, or mobilize and externalize the ureter as in cutaneous ureterostomy, or ligate the ureter just above the injury and plan a stage percutaneous nephrostomy. So these are the things you can do for unstable patient on table. Now what to do for a patient presented with delay injury? So for that, first investigate the patient, identify the site of the injury, like it is a proximal ureteric injury, or is it a distal ureteric injury, or it is in the mid of the ureter. So first to classify the ureter and then plan accordingly.